Hi, everyone. Thanks so much for joining us today for our webinar, CTEPH Updates, Making Sense of the New Clinical Practices. I am thrilled to be joined today by two physicians who work very closely with CTEPH patients in Canada. I'll introduce them in just a few moments. Before we get started, I'll just cover a few housekeeping items. If you have any questions throughout the webinar, I'll encourage you to post them in the question box. We will get to as many of them as we can by the end of the session. You can also use the chat box if you want to ask questions or just chat with other attendees or the panelists themselves. I'll remind you that today's session is recorded as always. So if you missed something, not to worry, it'll be posted on our YouTube channel sometime next week. Sometimes it can be a lot of content, and don't fret if you miss something. You can always watch it back on your own time. So let's start by welcoming our guest speakers for today's webinar. Both of the physicians today who will be joining us work at the Toronto CTEPH program. If you don't know what it is a multidisciplinary program that provides care for patients with CTEPH from across Canada. So Dr. Robin Ralph Edwards is a thoracic surgeon who completed her training at the University of Toronto just last year. She developed an interest in CTEPH through her work with Dr. Desperreaux. She is currently finishing her fellowship in CTEPH and PA surgery at the Toronto General Hospital. She's joined today by Dr. Marc Desperreaux. He is the director of the Toronto CTEPH program at the University Health Network at the Toronto General Hospital. Dr. Desperreaux's surgical activity covers PEAs, lung and heart transplantation, as well as ECMO, which, as you know, are all important components in the management of CTEPH and other causes of pulmonary hypertension. So without further ado, I will pass it over to the two of you. If you need me, I'm here. So thank you so much again, both of you, for joining us today.
Thanks very much, Kimberly, for having us. And I just also wanted to point out that we're also joined by Laura Littner, who's our nurse practitioner in our program today. And for CTEPH patients, she would be somebody that you would commonly see in our clinic and on the ward as well. So thanks again for having us speak with all of you today. So I thought I'd just start off with a bit of background on what pulmonary hypertension is, and not specifically CTEPH. So pulmonary hypertension is quite a rare problem to begin with. It happens when the blood pressure within the arteries of the lungs is abnormally high, and there are a number of different reasons why this can happen. And this is often due to narrowing of the arteries within the lung. This is very different from when patients have systemic hypertension within the blood vessels in the rest of the body, which is quite common and is often treated with just medications alone. So it's very separate. Some of the signs of pulmonary hypertension. So most commonly, patients will present with shortness of breath, but they may have other symptoms like chest pain, just more fatigue doing regular activities. In patients that develop right-sided heart failure, they can also get swelling of the legs, or if it's even more severe, they can develop lightheadedness or even loss of consciousness. The World Health Organization has made a classification system to help us to kind of decide the severity of symptoms that a patient who has pulmonary hypertension may experience. And so this is classified from class 1 to class 4, with class 1 being the least severe and class 4 being the most severe. So patients that have class 1 symptoms will have essentially no limitation in their daily physical activity. They're really not very short of breath when they're doing just routine exercise. In patients that have class 2 disease, they'll have mild shortness of breath or fatigue when they exercise, but when they're resting and doing other chores that are less arduous, they won't really experience very much symptoms. In patients that have class 3 symptoms, they'll have moderate shortness of breath or fatigue with fairly routine activities or chores around the house. And patients who have class 4 symptoms are really short of breath or very fatigued just at rest. Some of them will have signs of right heart failure, and some may even require home oxygen or experience loss of consciousness when they exercise. As we were saying earlier, there's a number of different causes for pulmonary hypertension, and the World Health Organization has grouped them into 5 different groups. So group 1 is called pulmonary artery hypertension, and there are a number of different diseases that fall into this category, such as idiopathic pulmonary artery hypertension, pulmonary artery hypertension that's associated with genetic conditions, scleroderma, cirrhosis, or patients that have occlusion of the veins within the lungs. Group 2 pulmonary hypertension is associated with diseases that involve the left side of the heart. So patients that are in left heart failure can have backup of blood flow into the lungs, which can cause pulmonary hypertension. Or if they have abnormalities within the valves in the left side of the heart, like the mitral or the aortic valve, it can cause a backup of pressure within the lungs and cause pulmonary hypertension that way. In group 3, the pulmonary hypertension is related to diseases of the lungs like COPD or pulmonary fibrosis or interstitial lung disease, or in patients that have obstructive sleep apnea. Group 4 is the one that we're focusing on today. So this only includes patients that have CTEPH or chronic thromboembolic pulmonary hypertension that's secondary to PE. And then group 4 is kind of a miscellaneous group that can include patients that have pulmonary hypertension from having sickle cell disease, sarcoidosis, chronic kidney failure, and other reasons. So how does pulmonary hypertension affect the heart? So normally as the blood flows from the veins within the body, it will go to the right side of the heart as it's deoxygenated from your muscles, and it goes through the heart and into the lungs to be oxygenated. But when there's high resistance within the arteries of the lungs, the right side of the heart will have to work against a higher pressure, and it has to work harder to pump the blood into the lungs and get oxygenated. Over time, this increased workload that the heart sees on the right side can lead to strain and weakening of the heart, which eventually can lead to right heart failure if it's left untreated after a long time. Chronic thromboembolic pulmonary hypertension, as we said, is pulmonary hypertension that's caused by a blood clot or a pulmonary embolus, a clot within the lung. And usually when patients develop an acute pulmonary embolus, they get treated with blood thinners for a number of months, and that helps your body to dissolve the clot and get rid of the obstruction that's within the vessel. But in a very small percentage of patients, scar is left behind after that blood clot is gone, and it causes thickening of the vessel, which makes it very stiff and makes it harder for the blood to flow within the vessel. Sometimes CTEPH can go undiagnosed for a number of years. So after a PE, some patients can be persistently short of breath for a very long time, and family doctors or other doctors may do certain tests to look for reasons why they're feeling short of breath and not find the reason. And that's because CTEPH is not diagnosed unless you do very specific tests. So very common tests that can be done in patients that are experiencing shortness of breath include a chest x-ray, lung function testing, or even a CAT scan that doesn't have IV contrast within the pulmonary arteries. And unfortunately, none of these tests will be able to pick up CTEPH. So that's why you need an expert to be able to help to make the diagnosis. Why is it important to diagnose CTEPH? So as we know, there are a number of different causes for pulmonary hypertension, but in many of those types of pulmonary hypertension, we don't have a good way to actually reverse the problem that's occurring. So for example, patients with idiopathic pulmonary artery hypertension, that's mostly treated with medications that help to temporize the problems, or in patients that have very severe pulmonary hypertension, sometimes lung transplant can be used, but doesn't actually reverse the problem with the medications. However, if patients are found to have CTEPH as the cause for their pulmonary hypertension, then we have a number of different treatment options that we can use to treat the problem. And sometimes we can cure CTEPH completely when we do surgery. I wanted to talk a little bit about some of the risk factors for developing this chronic scar tissue inside pulmonary arteries, because as we know, not everybody develops that after having a PE. So when they looked at studies of patients that developed CTEPH after having a PE, they found that having recurrent blood clots or repeated pulmonary embolus was a risk factor for developing this chronic scar tissue. Patients that were older in age had a bit of a higher risk of developing that scar tissue. patients that had a larger burden of clot at the time of their initial presentation with PE, or patients that had a longer duration of their symptoms. The Canadian Thoracic Society guidelines for diagnosing CTEPH came out most recently in 2019 with their update. And this was published in the Canadian Journal of Respiratory Critical Care and Sleep Medicine. So essentially what these guidelines are, they're developed by a committee of doctors across Canada who are expert in diagnosing and managing CTEPH. And so that included respirologists, cardiologists, radiologists, and surgeons. And they reviewed all of the literature since the previous guidelines, which came out in 2010, to see all of the available evidence and come up with a consensus on how we're going to be diagnosing, testing, and whether screening is useful in patients with suspected CTEPH. So I'll just go through those guidelines a little bit so we can have an update. So the first thing that they wanted to look at in those guidelines was screening. So they wanted to know if after a patient has a PE and is started on blood thinners, if it's useful for them to be screened for CTEPH. So we know already that the incidence of acute PE is fairly rare. So somewhere between 48 and 56 patients out of 100,000 will develop a PE. But very few of those patients who have a PE will develop CTEPH. We do know that it's very important to identify patients with CTEPH because that has a large effect on their quality of life long term, and because if it goes undiagnosed for many years, it can become life-threatening as patients develop heart failure. So it would be useful for us if we had a screening test that would be identifying these patients earlier to get us to treatment. So they reviewed all of the evidence that was available, and they found a meta-analysis of 21 studies that looked at screening patients for CTEPH. They did find that there was a higher prevalence of CTEPH in patients that had symptoms like persistent shortness of breath, difficulty with exercising, or chest pain after they were treated with blood thinners for 3 to 6 months. And some studies showed that when they used echo, which is ultrasound of the heart, they were able to identify some patients that had pulmonary hypertension after having a PE. But when studies tried to screen patients systematically for CTEPH after having a pulmonary embolus, there was no change in the degree of detection of patients versus if those patients were just investigated normally if they developed ongoing symptoms after they were treated for a few months with blood thinners. So after reviewing all of the literature, they basically concluded that unfortunately routine screening doesn't seem to be effective because CTEPH is rare after a PE, and the patients that develop CTEPH after having a PE are very symptomatic afterwards, and so we would be able to find those patients regardless. Even in patients that are at a higher risk of developing CTEPH, such as patients that are older in age or have had recurrent PE, we don't have evidence right now to suggest that screening in patients that don't have any symptoms will help to improve the detection of the disease. But in patients that still have unexplained shortness of breath or other symptoms after they've had 3 months of effective blood thinners, then those are the patients that should be investigated further. So what tests should we do? So we know that making a diagnosis of CTEPH can be difficult, and it often requires a number of different tests to be done to kind of formally make the diagnosis. And so it's really important to work with your doctor to decide which tests are needed. Most of the tests that we do are non-invasive, but there is one test that we do that's needed to accurately measure the blood pressure within the pulmonary arteries, which is a small invasive test. The most common test that we start out with is called a VQ scan, or a ventilation perfusion lung scan. So this is the gold standard first test and is non-invasive. So for this procedure, a patient is asked to inhale a radio tracer, and then a special machine will take pictures of the lungs to show where that radio tracer goes when the patient inhales, basically showing where oxygen goes within the lungs. And then they take another picture after injecting contrast dye into the blood vessels to show where the body circulates the blood within the lungs. And then we can look through these pictures to see if there's areas of differences between where the lung is being ventilated versus where the lung has blood flow. And so in that test, that will be abnormal in somebody that has CTEPH. The next test that we commonly do is called a CT pulmonary angiogram. And this is a special type of CAT scan that we do where we inject contrast dye through the veins, and it goes into the pulmonary arteries so that we can see them very clearly. You can see in the top picture here that the pulmonary arteries are very, very bright, and that gives us a sense of whether there's areas of scar along the lining of the vessel, or if we can see little webs that are obstructing the blood flow. This is, again, another non-invasive test. Another test that we commonly do is called an echocardiogram, and this is basically an ultrasound of the heart. So they put a little bit of jelly on the chest, and they use an ultrasound probe to take pictures of the heart as it moves. This helps to give us a sense of if there's any signs of pressure or fluid overload within the right side of the heart. Sometimes patients can also get leaky valves on the right side, which can be a sign that the heart is working against increased pressure that's flowing back into the heart. The right heart catheterization is an invasive test that we do where we measure the blood flow directly within the pulmonary arteries. So with this test, we use a small catheter that goes in through one of the veins and into the pulmonary artery directly, and has a little sensor on the end of it to measure the blood pressure directly within the arteries themselves. Sometimes in patients that we think will need to go on to surgery, we'll combine this procedure with a coronary angiogram, which is a similar type of procedure, but it looks at the blood vessels around the heart in patients that are at an increased risk of having coronary artery disease, because sometimes we need to do a coronary bypass procedure at the same time as our pulmonary endarterectomy procedure to get rid of two problems at once. Other testing that we do routinely, so we always have our patients complete breathing testing, so pulmonary function testing, and they also will do a walking test where we see how much distance patients are able to cover within 6 minutes and whether their oxygen levels decrease when they're exercising. In certain scenarios, we can do other testing to help to clarify the diagnosis if all of those tests haven't kind of given us the full picture. So those can include a pulmonary angiogram, which gives us a very clear picture with interventional radiology of the blood vessels within the lungs. Cardiopulmonary exercise testing, where we put a patient on a bike and we help to measure your body's response to exercise, and a very special test called a breath study, which is a right heart catheterization, where we ask the patients to exercise when they're doing their procedure, so that we can measure the actual change in blood pressure within the pulmonary arteries when patients are exercising. From the Canadian Thoracic Society, they've recommended that in patients that we think have pulmonary hypertension, the first test that we should do is the VQ lung scan, because that's the best test that will rule out a diagnosis of CTEPH. So patients that have CTEPH will always have an abnormal VQ scan. And then after we have that scan, we can go on to other tests. And the next one that they recommend after that is a CT pulmonary angiogram, which will give us a better picture of how the inside of the blood vessels look. Next, I'm going to move on to treating CTEPH, because we have a number of different ways that we can treat it. So currently we have 3 options for treating CTEPH patients. The first option that I'll talk about is surgery with a pulmonary endarterectomy. Next, we have something called balloon pulmonary angioplasty. And then the third option that we have is medications for treatment. When we're deciding how to treat CTEPH, we have to tailor the treatment to each individual patient. And that's why it's really important for patients that have suspected CTEPH to be referred to a center that specializes in pulmonary hypertension. For us, we have a multidisciplinary rounds review every week where we discuss with surgeons, respirologists, interventional and diagnostic radiologists that help us to make decisions in patients that are a little bit more complex. So I'll next talk about pulmonary endarterectomy. So pulmonary endarterectomy is a surgical procedure, and it's the treatment of choice for patients that are eligible for surgery. And it's the only option that we have that actually removes the scar tissue that's formed inside the blood vessels. Once we remove the scar tissue, it allows the blood pressure within the pulmonary arteries to return to normal. And over time, that allows the heart to recover and return to normal function with time. Not everybody is a candidate for surgery, unfortunately. So for one, when we see you in consultation, we need to assess to make sure that you would be strong enough to go through the surgery, as it is a big procedure to have done. And sometimes we will have patients that will have to go through a little bit of rehab or medication optimization before they go on to surgery. And then the other factor that influences the decision for surgery is where the level of disease is. So there's a classification system that we use to identify how far away the scar tissue is from the main vessels, and that helps to determine whether we would be able to reach it with surgery. So for the surgery itself, we make an incision through the breastbone in the middle of the chest, which helps us to access the pulmonary arteries. We put the patient on the heart and lung bypass machine, or cardiopulmonary bypass. After that, we cool the body down to 20 degrees to allow us to temporarily stop the machine and open up the blood vessels and remove the scar tissue inside. This is a picture here of what the specimens look like that we remove. So all of this is scar tissue here in the top corner. Once we've done the procedure, which takes the full day, the patient goes to ICU for somewhere between 2 and 4 days on average. And generally, we keep patients in hospital for around 2 weeks. The shortest amount of time is somewhere around a week usually. In the long term, we've looked at our results in terms of overall survival, as well as quality of life, and we found that our patients have excellent long-term survival and improvements in quality of life in terms of their physical activity, their general health, their energy, and their social functioning is all much improved after surgery. The mortality of the procedure is around 2 to 3%, so this is a big procedure to have done. And patients will still need to be on lifelong anticoagulation to prevent this from happening again. In Canada, the Toronto General Hospital is the main referral center for patients that need surgery for CTEPH. And within our surgical practice in the past year, we've received 180 referrals. Currently, we're doing about 60 cases per year. And as you can see, over time, we've increased the level of disease that we have been operating on. And so we're operating on more complex patients, and more patients are becoming surgical candidates as we continue to progress. In terms of where our patients come from, so about half of our patients are from outside of Ontario. Within the last year, we have about 1/3 of our patients are from BC, and another third almost are from Alberta, and then smaller percentages from other provinces. The next option for treatment I'll talk about is balloon pulmonary angioplasty. So this is a newer treatment that we have available for patients who may not be surgical candidates, or for patients that have already had surgery, but they have some residual pulmonary hypertension years down the line after having their procedure. And so this works similar to help to reduce the blood pressure within the pulmonary arteries, to reduce the amount of work that the heart has to do to pump the blood into the lungs. And it also helps to improve the blood flow to the lungs, which improves shortness of breath. This procedure is done by an interventional radiologist, and it's minimally invasive. So they go inside the veins and into the pulmonary arteries, and they find the areas where the scar tissue is present. And with a small catheter, they find that location and they inflate a balloon to help to stretch or dilate those blood vessels to improve the blood flow in that area. You do need to be admitted to hospital for this for monitoring, and it does require multiple sessions, usually 4 to 8 sessions, to have success. The last option for treatment that I'll talk about is pulmonary hypertension medications. The most common medication that's used currently is called riociguat or Adempas. So this is commonly used in patients who are not candidates for surgery, either as medication alone or as a complement to a balloon pulmonary angioplasty. And it can also be used in patients that have leftover pulmonary hypertension after they've had their surgical procedure. It works in two different ways, but basically how it functions is it dilates the blood vessels within the lungs to help to improve the blood flow in that area. When they did testing on this medication, they showed that it had improvements in patients' ability to walk further distances after it was used, and it also decreases the resistance within the pulmonary arteries in patients that have pulmonary hypertension after surgery or in patients that were not candidates for surgery. Other medications that you may be familiar with include bosentan, macitentan, or sildenafil that are also commonly used for the same reasons. These medications need to be prescribed by a pulmonary hypertension specialist because it's very important to monitor the treatment effect and to ensure that there's no other side effects. In general, we don't like to use medications before surgery in patients that are surgical candidates, but in very rare circumstances, such as if patients are too sick and we think that they would benefit from some medication beforehand, sometimes that can be done. But in general, medication has been shown to delay surgery, and sometimes it can even make surgery more difficult. So we try to stay away from that if possible. Looking ahead, I think that all of us would like to increase the awareness of CTEPH as a rare and very treatable form of pulmonary hypertension. We're also working continuously to improve our access to quality care for Canadians and decreasing the amount of wait time for specialized procedures such as surgery or balloon pulmonary angioplasty. And as we progress, we're doing research on new drug therapies to improve the outcomes in patients that can't have the other treatments that are available. So to summarize, CTEPH is a cause of pulmonary hypertension that happens quite rarely after patients will suffer from a pulmonary embolus, so around 4% of patients that develop a PE. And in many of these patients, the disease can go undetected for quite some time because it's not visible with common tests. So you have to do specialized testing like VQ scans, CT pulmonary angiogram, right heart catheterization, or echo to help to make the diagnosis. We know from the studies that we have available so far that screening for CTEPH in patients that have had a history of a PE in the past so far has not been proven to help to find more patients with the disease or to help to find them earlier. And it's very important to have a multidisciplinary review by surgeons, respirologists, and radiologists to help to make a tailored treatment plan for each individual. And this can involve a combination or any of surgery, balloon pulmonary angioplasty, and different types of medications. I'd just like to say thank you again for having us join today. Maybe we can open for some discussion.
Thanks so much, Dr. Ralph Edwards. Now would be a great time if you have any questions to post them in the question box or the chat box. I'll mention while you do that, my video back on, that you had mentioned that the Canadian Thoracic Society had put out its clinical practice guidelines. PHA Canada has recently created a patient summary of those guidelines. So just a shortened version that's a bit more digestible for the patient community. I will send a copy of that out to all those on the webinar today. You can find it on our website as well. So we'll send that out. It's just a great summary version of a very long document that can be a little hard to digest for folks. So we'll send that out. But if you have any questions, or Dr. DePerro or any of the Lauras on the line, do you have anything that you'd like to add to the presentation?
Yeah, well, first of all, thank you as well for organizing the webinar. I think this is very important. Thank you for all the work that PHA Canada is doing, to increase awareness, increase understanding of the different conditions related to pulmonary hypertension. And I think as Robin mentioned, awareness is still a key part in this disease on PH in general. Also, thank you, Robin, for an excellent summary. I think that was very well presented and summarized.
Thank you.
And so we have, Laura Littner and Laura Tombolini here as well, who, have been also very directly involved in the care of our patients. On one key part, I think that we have learned over the years is really the critical part to prepare patients for surgery, but also to follow patients in the long term. Now we've realized that now that we have more treatment, that sometimes one treatment is not enough. On the combination of treatment is really an area that has developed quite largely, in our program and across most of the large CTEPH program in the world. So this is really a multidisciplinary, team in terms of treatment. The other part that is starting to emerge as well is the anticoagulation. Increasingly we get away from the warfarin or the coumadin for anticoagulation and use more of the directed anticoagulant. And this is an area that is also being evaluated to see, the safety of these drugs. And occasionally we do have to switch to other treatment on the directed anticoagulant. And postoperatively, we tend to avoid them for a few weeks to a few months to limit the risk of new clot during the healing process after the surgery. So these are, some of the changes that have occurred on that are also part of our focus in terms of optimizing the treatment for CTEPH.
Great. Thank you for that. I don't see any questions coming in. Oh, just as I said that, it just always seems to pop in. So Annie is asking, what are the risks of having EP while on blood thinners?
Yeah, so it's a great questions. The risk is low in general. I mean, the blood thinner works extremely well, including the new ones. But some of the, occasionally some of the patients may what we call breakthrough, so they develop a new clot while on blood thinner. So there can be two reasons for that. One is that, the blood thinner is not effective enough on the new blood thinner. The directed anticoagulant target only one molecule. The warfarin and the heparin target, multiple site, multiple molecules along the coagulation pathway. That's why they are more efficient. So sometimes one of target is not sufficient with the directed anticoagulant. The other part that we see as well is that once there is a diagnosis of CTEPH or chronic thromboembolic disease, the blood does not circulate well through the lung. So sometimes there can be new clot that forms inside the lung just because of the disease itself. And once you treat the disease, the blood circulates back more, freely, and the risk of clotting inside the lung is actually decreased. So the new clot can be just related from the disease itself rather than a lack of efficiency of the blood thinner. But in general, this anticoagulant works very well. And in order to be sure that they work well, generally we will wait a few months on anticoagulation before the surgery to make sure that they work well, and then go back to the same anticoagulant after the surgery and for the long term. So we always wait 3 months after the start of the anticoagulation to make sure that the disease has time to heal, and so we can see what is becoming more like a scar tissue rather than a clot. And if there's a change in the anticoagulant, generally we will wait again a few months, to proceed with surgery unless there is no severity of the condition with the stress on the heart that precludes us from waiting too long. But the anticoagulation is certainly a key part of the treatment that needs to be monitored in the long term.
Thank you, Dr. Defoe. Beth is asking for some clarification. At the beginning, Dr. Edwards, you mentioned that pH is rare, and you spoke specifically about the 5 different WHO groups. She's asking for clarification about which of those groups is considered rare. She was under the impression that it was just group 1 and group 4 that were rare. What is the thought on the other groups? Are they rare as well, or are there more groups? There are other groups that are more rare.
I think pulmonary hypertension in general is quite rare. Yeah.
Yeah, would you say that that CTEPH is particularly more rare than the others, or would you qualify them in some order?
I think maybe Dr. DePro, in terms of the actual numbers, but I think that the problem is that CTEPH is often misdiagnosed, or, so we don't maybe truly have accurate representation of the number of patients that have chronic pulmonary hypertension after PE. So that makes it a little bit difficult. From what we know, it's around 4%, but.
Yeah, no, that's right. So the the CTEPH, I mean, PH in general is relatively rare. At least, group 1 and group 4 are probably, quite rare compared to group 2. So group 2 is the most frequent with no heart disease. Group 1, group 4 are less frequent. But as Robin mentioned, the more you look, the more you see, at least on the CTEPH side. So CTEPH is still largely underdiagnosed and can sometimes be mislabeled as group 1 if you don't have the high resolution CT scan or a VQ scan. That's why anybody who seems to have a group 1 PH needs to have a VQ scan to really rule out the group 4. But as experience increase and awareness increased, in Ontario, Southern Ontario, we do see that the number of patients with group 4 is actually becoming quite predominant compared to group 1. So we do see more group 4 than group 1 in Toronto, because part of it is because of the expertise. So we do see patients beyond just Southern Ontario, obviously, but even so, we do see a large number of group 4 compared to group 1. And part of the difference is that we do see also a large number of patients who have had a blood clot but don't have very severe pulmonary hypertension. So some patients have scar tissue from the blood clot, and the pulmonary hypertension is still at a very early stage in the process. Yet it can be very disabling and very limiting and affecting the quality of life. So these are a group of patients that we see on that we can treat similarly to CTEPH, although the pulmonary hypertension is at an early stage. What is still an area of investigation is the risk of progression to pulmonary hypertension. So if somebody doesn't have pulmonary hypertension but has chronic scar tissue from blood clot, what is the risk of developing pulmonary hypertension? It seems to be very low or extremely low, but we don't really know the exact number. But once there is pulmonary hypertension, then the disease progresses despite the blood thinner. So the pulmonary hypertension leads to a vicious circle, and unless you remove the scar tissue and stop the process, the disease will progress despite the blood thinner. So blood thinner is not a treatment for CTEPH, but it is a preventive treatment for the blood clot. So the treatment for CTEPH is really the resolution of the scar tissue that is built up from the clot.
Thank you. There's a question in the chat. Kim is asking, are ultrasounds, carotid, arterial, or venous required for the workup?
Yeah, so we do these ultrasound preoperatively. A lot of the main goal of having them is to have a baseline, particularly for the venous ultrasound, just to have a baseline to make sure that often there is abnormality, to make sure that if there is a problem after the surgery, that to determine whether it's new or not. So having a baseline allows us to compare. And sometimes we do this venous ultrasound also to check the neck or the arm, particularly before surgery, because you have to put the catheter from the upper part of the body through the vein, and we want to make sure there is no clot there. So these are the venous ultrasound that we do. We do also check the artery here, and that's purely for the surgery to make sure that there is no blockage in the main arteries, going to the brain or to the leg, and limit the risk of no problem from that perspective. So these are just a checkup that we do.
Thanks for your question, Kim. Vanessa is asking, I'm 80 with existing PAH, diagnosed in 2018, then clotting and symptoms, and despite continuing on blood thinners, I'm waiting confirmation. Would this be CTED rather than CTEPH?
Well, if there is pulmonary hypertension, then it will be CTEPH, CTED or CTED is only when there is no pulmonary hypertension. So if someone has PAH, so they have pulmonary hypertension at baseline, then the question is whether the pulmonary hypertension is from the clot or from the small vessel in the lungs. These are the tests that, like the VQ scan and the CT scan on the pulmonary angiogram, that help us to define that. And that's where the quality of the test is important. Sometimes the scar tissue from the clot can be in the small arteries of the lung, and they can be hard to see. But that's what define PAH versus CTEPH. No, CTED or CTED versus CTEPH is defined by pulmonary hypertension. So that's from the right heart catheterization. Sometimes you can have patients with PAH group 1 on acute blood clot. That can happen. It's certainly not frequent, but it happens. And we've seen a number of patients having these two components. But the blood clot can be resolved and not leave scar tissue, on the PAH can not be related to the blood clot or related to a mechanism that we don't see on the CT scan or the VQ scan typically here. Now, the difference between the group 1 and group 4, clearly the surgery and the balloon pulmonary angioplasty are two key treatment components. Now, if surgery or balloon pulmonary angioplasty are not treatment component, then the medical treatment becomes the key part of the treatment. And there is a lot more options if you have PAH than CTEPH. In CTEPH, in Canada, it's really the add-on pass that has been approved. In PAH, there is access to multiple drugs, 9 or 10 drugs. So the ability to have access to drugs is quite helpful in the management if there is no surgery or BPA possibility here. And sometimes if it's in between, then we will give the benefit of the doubt to have access to other drugs as well, which is an important part of the treatment.
She is clarifying that her PAH diagnosis preceded her clots. Would that change your answer at all, Dr. DeFerro?
Not necessarily. I think the key part is really what the investigation will show with the VQ scan on the CT pulmonary angiogram. On the VQ scan is really the key part. The VQ scan is the most sensitive test to make sure that we don't miss the diagnosis of CTEPH. If somebody has a normal VQ scan, so no abnormality on the perfusion on the lung, on the VQ ventilation perfusion lung scan, the likelihood that it is missing the diagnosis of CTEPH is very low. It's less than 1 or 2%. So this is really the key test to rule out the diagnosis. If that test is abnormal, then the other tests become more important.
Thank you. Annie is asking, if there is a new blood clot, will they be visible on my next ABP?
What is
ABP? Yeah.
Annie, could you maybe clarify what you are referring to, and then I'll come back to you. If you could clarify that in the question box, that would be great. I'll move on then. Jazz is asking, is there an age limit on the PTE or the BPA? That's a great question.
Yeah, no, great question. All these questions are very pertinent. So it's great to see. So there is no age limit per se. It's really more the function of the patients, the impact of the disease on the quality of life of the patients, on the ability, on the risk related to the surgery. The risk of the surgery is quite variable depending on the severity of the pulmonary hypertension, the location of the scar tissue that will direct the surgery here, on the severity of the heart failure. So on the risk between PTE and BPA are also quite different. Obviously, BPA is a lot less invasive. It's not available for all patients. It's really when the disease is very deep into the lungs, and it is associated with the need for medical therapy. But there is no age limit. It's really the function on the risk on the situation that leads to one treatment or the other, or none of the two. In terms of surgery, just to give you a number, like the youngest patient who had a pulmonary arterectomy was 3 years old. on the older was almost 90-year-old. So
90, yeah.
so it is a wide range. You know, the older patients get, the higher the risk of having scar tissue from blood clot. So the average age of patients who have pulmonary endarterectomy in general is about 60 years old. So that means about half of the patients will be, you know, older than 60. So mostly patients, you know, over 60 will have surgery in general.
Wow, 90, that's amazing.
Mm-hmm. Yeah, so no, it really is dependent of the, you know, the general functional condition of the patients, and that's where, you know, early diagnosis is quite important, because sometimes the disease can progress for a very long time, and some patients may have disease for 10 years. So if they're diagnosed at 70 years old or at 80 years old, it makes quite a big difference. And you know, as the heart gets weaker, then it makes the risk of the surgery higher. Yet, no, we still proceed depending of the situation, but it does increase the risk.
Just to go back to Annie, elle est francophone, alors elle avait
Oh, okay,
discuté
perfect.
avec,
Great.
yeah, she was having trouble with the term. So she's talking about an angioplasty pulmonaire à ballon. So she's asking if there is a new clot, will it be visible when she has her next test?
Yeah, so I'll do it both in French and English, I guess.
Sure, merci.
Perfect.
Anglais. Yeah, so you will be able to see it on the pulmonary angiogram. So if you do a pulmonary angiogram to assess for balloon angioplasty, you will check every arteries of the lung on you know, particularly if there was one before, then that can be compared. So it will be picked up. So oui, vous pouvez voir les nouveaux caillots sanguins au niveau des artères pulmonaires pendant l'angiographie, il n'y a pas de doute.
Alors, merci. C'est pour ça qu'on est bilingue, alors.
Ouais.
And Denise is asking, what do you see as the most common side effects of riociguat?
Yeah, so the riociguat is given by our colleague in you know, on the medical side. So they are the one in charge. But you know, the side effects that we monitor very closely is the drop in the blood pressure. So when the medication is started, it started at a low dose, and every 2 weeks or so, the dose is increased to make sure the blood pressure doesn't drop. And if it does, the other medications also, if there is medication for high blood pressure, that can be kind of readapted. A side effects that we've seen occasionally on is not necessarily very severe, but may affect some patients is the, you know, gastric bloating or kind of affect a little bit of the digestion. So that's a gastric bloating is something that we've seen, you know, occasionally here. There are certainly other side effects, but again, we, you know, in terms of leg swelling on so there may be some other side effects that are less common, but the blood pressure component is a side effects, but is unexpected side effects, and that's why the medication is kind of slowly build up to make sure that it is not too impactful on the blood pressure.
Thank you. I think we've come to the end of the questions, unless someone pops one in quickly, but I want to thank you all so much, the wonderful team at the Toronto CTEPH program. If you find yourself with these folks, you're in wonderful hands. Not only are they friendly, but they're very knowledgeable. If you have some time to digest all this information and still have questions, please feel free to reach out to us at PHA Canada, and we can absolutely put you in contact with these knowledgeable folks. Again, thank you all so much. I appreciate your time, and thank you so much for helping us digest some of these complex issues and ideas. So I really appreciate it. Again, if you want to rewatch this webinar and take it all in again, you can tune into our YouTube channel and watch this and many other webinars that we have featured there. So thank you all again so much.